Hi everyone, so my name's Kerry Leeson Beavers. I'm the Chief Executive of Alström Syndrome UK and Breaking Down Barriers. I'm a patient representative on England's Rare Disease Framework Delivery Group, and I also take part in lots of different research projects looking at particularly around patient and public involvement and engagement. So great to be here. Over to you, Tim. You're on mute, Tim.
Do apologise. My name's Tim Barrett. I'm a children's doctor based in Birmingham Children's Hospital and Birmingham University. I've been interested in rare diseases for a long time because of my practice in paediatric endocrinology, and I've been involved in setting up and delivering 3 highly specialised rare disease services, but also some regional ones that haven't had highly specialised funding, getting industry funding money in, and also some local ones where we've not had that funding too. So it's a great pleasure to be here and share my experience.
Thank you both. So we're now going to open up to questions. So if any of the attendees have questions, please put them into the chat. I've got a couple to start with. So first question is to Tim. Is it possible to create a highly specialised service for a condition that doesn't attract support from industry partners?
So yes. So I've been involved in 3 services like that. So the Alström service, Wolfram Rare Disease Service, Bardet-Biedl service, none of those when they started had industry sponsorship, and there were no treatments or drugs available. So very much the key things I think for the highly specialised services was to demonstrate that a service exists, that you start a service off on a goodwill basis, I guess, that there's a patient need there, that there's a clear pathway, and that the service can clearly benefit by either earlier diagnosis, screening and treating complications, or improving the quality of life of participants to do so. And you don't have to have a cure or a licensed treatment to set that service up. That's really, really important. The vast majority of services, I suspect, started before treatments were available. And it's only in latter years that we've had a treatment for Bardet-Biedl syndrome, for instance, and we're still waiting, hopefully, for one with Alström syndrome. Yeah.
Brilliant, thank you. Next question's for Kerry. What examples have you got of best practice for engaging a diverse range of patients and avoiding over-representation by a small number of dominant voices in patient organisations?
Yeah. So I think sometimes, we really need those dominant voices. So I think I don't want to, I think sometimes we can see that as a negative, but I think it's also real positive as well that we need people really who can advocate and shout loudest. I think often we hear that a lot in the rare disease community. We need to shout loud. But also I think some of the good practice really is finding different ways to involve people. So we've developed Breaking Down Barriers, which is looking at improving engagement and involvement with people from diverse, marginalised and underserved communities. So it's really making that extra effort to go out and find families, to work directly within communities, to develop more face-to-face work. I think, we do a lot of work now online, and that's been a positive step for a lot of things. But actually when it comes to engagement, building trust, building confidence, sometimes that's a barrier. So I think I'd always try to maintain that the need for that in-person interaction as well. And I think, we've got an Experts by Experience advisory group, and it's a group of people who maybe haven't taken part in, the roundtable meetings and high level meetings that some people can find really daunting. So I think it's often, starting with peer-to-peer support, starting with small groups, really looking at ambassadors, community ambassadors are really powerful, but also that peer-to-peer support. I think when you look at when we started with the Alström service, with very little diversity, we've needed to build that up over time through those small steps and really building trust, but I suppose delivering on what we say we're going to deliver. So we say that we're going to do something. We often talk about being a patient-led service, that's, but what we need to keep showing is actually what we're delivering is in response to what people are telling us that they need from us. So yeah, just a few tips there.
Okay, thank you. Okay, next question is to Tim. What evidence has mattered most when showing commissioners that a rare disease service is working and making a difference?
Yes, so when we set up the service, we had to set up some key performance indicators that were agreed at the beginning, and they didn't want those changed because they wanted to be able to compare from year to year and over a longer period of time. So in this particular service, for instance, it was can the age at which patients are diagnosed fall? So for that, they wanted to show that the diagnostic odyssey was being shortened for participants. And this service started in 2008, and the genetic test had only been available really for about 7 years at that point, something like that. But patients were coming to clinic aged 14 or 15, just being diagnosed. Thankfully, with good genetic counselling input and the availability of NHS genetic testing, we're able to get that age of diagnosis down to below 5 and even younger than that as well over time. So families are happy with that. Another example, when we started the service in 2008, almost half of the children we looked after had insulin-resistant diabetes. And over the time since then, not due to drugs, but due to really good parental support, better understanding of the condition and dietetic input, we're now left with about 3 children in the service with diabetes. So hardly anybody now, thankfully. It's really improved. But as a result, we're now aware of other complications like fatty livers and things that need to be treated as well. So our focus is now does evolve, even though the KPIs haven't changed. So our focus is moving on to other things. And then the third KPI that was relevant to Elvstroem was the number of children with a very high body mass index or obesity level should fall. And again, that's dropped quite dramatically over the 20 years or so of this service that's been going, 19 years, which has been great. And that's also now partly due to the advent of drugs as well. But these are hard clinical outputs that we do need to demonstrate to commissioners, as well as the ability to screen for and manage complications as part of this.
And just a follow-on question from that as well. When you're thinking about developing a service, when would you bring in those conversations with commissioners?
So I would bring them in earlier on, as early as possible. I think ideally when I would try and set up one of these services, I've got a group of clinicians in mind or experts in the different specialties that are willing to work together to try and build a multidisciplinary service for this. We would sit down with the patient support group and the commissioners to agree what sort of key performance indicators should go in, and then in that 3-way discussion, clinicians, patient support group and commissioners, we would agree and write the application to the commissioners for that service with agreed KPIs, which of course have got to be smart. They've clearly got to be measurable so that the commissioners can see that we're delivering what we said we were going to deliver as part of this. And most importantly, relevant to patients, of course, as well.
Brilliant, thank you. Next question, and this is to you, Kerry. In what ways do services tend to underestimate the support patients and families need outside clinic appointments?
I think sometimes it's really tricky for clinicians because they have very limited amount of time to be able to go through the things that they need to go through. And I think that's one of the advantages really of having a patient organisation involved. So sometimes it's not just following up after clinic, but it's the issues before clinic as well. Because of the relationship we've got with families, we often understand what some of those challenges are, and we might know that sometimes it's not necessarily directly the health challenges, there are challenges with education, social care, benefit system, all those kinds of things, where actually you need a lot of evidence from healthcare professionals. So if we're aware of some of those things beforehand, we can get what we need when they come to clinic to be able to support them as well. But I think the follow-up, it's, specialist clinics are fantastic in that you've got the expertise and people who know the condition well, but actually that's patients will visit those clinics probably once a year, if that. Sometimes it may be every 18 months or 2 years, depending on capacity issues within the service. But then their care then is delivered locally, and sometimes that's really challenging because you've still got the lack of knowledge about the condition, and you're still reliant on people reviewing notes, and because medical records aren't joined up and things, there's still so many barriers that people experience. So I think there's a lot of work that we can do to help support families through those challenges, and then feed back to the team. And because of the relationship we've got with the team, we can get any of the information or support that we need in the meantime as well, or be able to advocate for that advice for local providers as well. We work with the hospital teams to deliver training to schools, for example, who've got pupils living with Alstrom. So there's those, and also thinking about the Tim mentioned the high BMIs, and diet and exercise is so crucial. You can have a dietitian and a doctor telling somebody that they'll need to lose weight, but then it's like, how do you do that, particularly if you're deaf and you're blind, and and the additional support that you need? What we can do is follow up on that. We can provide equipment to help people to be as active as possible. We can advocate for personal assistance through direct payments, so we can, the advice that's given at the clinic, we can really help people to follow through with that and implement that, in day-to-day life.
Okay, thank you. So we've got a question here. How can services build in measures of equity and accessibility early?
I think in terms of accessibility, for me, it's having that understanding of what some of those accessibility challenges are, and that may be, if you might look at a condition such as Alstrom, and you automatically think, because they're deaf and blind, there's certain things in terms of the information that's provided that you need to make sure is accessible and things. But it's also being able to access the service. So when we talk about the language barriers within our community, it's making sure that we've got the interpreters and things, but actually just having an interpreter on the end of a phone during a highly specialized clinic isn't always adequate, because you're moving from one appointment to another to different tests, and actually people need that level of support throughout their whole visit. So you need an interpreter in person. So being able to kind of have that understanding early on really helps you to look at how when you're designing a service, how that will be delivered. And in terms of equity as well, thinking about the different types of support that somebody might need and where they live, and is having that one centre of excellence, is that going to be accessible for every patient to access? For our service, it works. It might not work for people from other services, and then it puts some patients at a real disadvantage if they then can't travel to that service. They're then not necessarily getting that equitable service. So yeah, I think there's there's lots of considerations, I think, that need to be taken at the beginning, but I think it's then that continuous evaluation that we need to do and adapt as needed. Anything else you'd add there, Tim?
Yeah, so I think we've learned a lot along the way about this issue. So to give some practical examples, I think so interpreters you've mentioned at the moment, we've had some families where they've got another child with a chronic long-term illness, making it very difficult to travel to Birmingham. So I've liaised with the local, my opposite number in the local hospital, in Manchester Children's Hospital, and arranged for them to be seen there, and then using a Teams link or a video so we can have a joint consultation that way to avoid the need for travel. Trying to understand what the travel needs are for families to do so. For some of the video clinics that we did, understanding digital poverty, and some families have had to go to a relative further up the street who's got a mobile phone access or whatever to actually join into this, and trying to make sure that any telemedicine clinics we do are equitable for other members to join. Thinking about particularly if we've got a population from certain faith groups, and trying to avoid doing a clinic during Ramadan because they can't travel on that time, for instance, and trying to take into account those sorts of needs as well. So we're trying to implement, again, through the Life Out project as well, diversity training, so that we can be a bit more culturally aware of the needs of our populations. And if I had my time again, I'd have implemented that from the outset, I think, but I perhaps wasn't so aware of those issues when we set the services up. Yeah.
Okay, brilliant, thank you. So next question is, where do services most commonly go wrong when engaging with industry, particularly in early stage development?
Oh, that's a tricky one. I'll start off, and then I'll probably hand over to Kerry, who's perhaps got more experience on it. But I think one thing we found is that we've engaged with industry when a drug has become licensed for a particular condition, and then they've supported personnel in the clinic to deliver a specialist clinic. But unfortunately, that's time limited. So then what do you do when that drug goes off patent, or other drugs become available, and industry money gets diverted somewhere else? And then you're left high and dry unless you've got succession planning or sustainability planning for a particular service. So I guess that was a learning point. I think from the outset, in engaging with industry, bear in mind that it's usually going to be time limited, and you need a plan for succession planning or sustainability planning if and when that funding should come to an end. Kerry, you've had more experience on the research side, haven't you?
Yeah, I think the main thing for me is not engaging with us early enough. you know, that things have gone too far, you know, the trials are designed, but then you can see there are so many pitfalls in that, in terms of it's not necessarily an accessible trial, particularly for a cohort like ours. So I'd say, you know, really engaging as early as possible, so that we can input, because you often find that, you know, patient organisations are really willing and, you know, and want to be able to, obviously often restricted on time and capacity and things like that, but would really want to support, you know, right within in those early days.
So another question, would you be able to share how you collect quality of life data when evaluating your service, please?
Yeah, so if anybody wants to contact, I'll put my email address in the chat, and I'll be able to share examples of the different information that we gather. I think when we were looking at quality of life and the kind of surveys and things that we've done, one of the things we made the mistake of, you know, doing really complex surveys and asking lots of different questions, and we got very little response. The best response that we've had is really stripping it back and asking a few questions, but then, you know, our response rate has really increased. So we've learned a lot of lessons through that. And I think, you know, in terms of the quality of life, we get a lot of that through the conversations that we have and the consultations that we do with people. So it's just making sure that often it's more difficult to measure, because we have to do the standard, you know, feedback forms, as Tim was saying, so that we can measure and compare over time. But a lot of the quotes that we gather are the things that really demonstrate the impact of what we're doing and the impact it's having on people's quality of life.
And there's the obvious thing that the questioner probably knows as well. So collecting that quality of life or that feedback data at the time of the clinic, rather than sort of a week later, or when people will have forgotten about it. And where it's possible, and if the digital technology allows, obviously having a QR code or something to be able to collect it sort of in real time is obviously helpful. But that's not always practical. It's not always practical for a condition where there's multiple sensory disabilities, etc.
And we try and cover both. So we'll have the cards available at clinic. Sometimes parents, carers want to fill that in as well, because we collect feedback from parents, carers, as well as people living with the condition. So you've got the QR codes there in terms of accessibility, so that people can use their phones. We also offer to send things via email as well. But I think sometimes when people have had a really stressful clinic, sometimes it's a time when they want to give their feedback because they really might not be happy with something, but actually sometimes they just want to get home because it's been a really stressful couple of days. So sometimes it is, you know, giving time to reflect and give some feedback afterwards. So we try and cover all bases, really.
Brilliant. In your experience, what is the difference and alternative added value of overarching services encompassing several rare conditions within a group, mechanistic, for example, versus a condition-specific service?
So I guess I'll start off with this as well. We've looked to try and do that model, and I know that model exists in other parts of the countries. It allows some economy of scale. I think that's the important thing. So if you've got a collection of diseases such as neuromuscular disorders, for instance, or ciliopathy disorders, some of them might need an orthopedic surgeon, some of them may need a cardiologist, some of them might need a respiratory doctor. If you can have an all-encompassing service, you can then draw on those experts as you require for particular clinics in it, and you can have a shared clinic support services, shared clinic administrator, for instance, a shared appointments booking system, for instance, shared travel. And given that there are 8,000 rare diseases and some of them can be grouped into groups like that, it's a logical way to try and take services forward if possible. It's going to be hard to develop 8,000 bespoke individual rare disease services, I suspect. So if we can group some of them together, that's important. The downside, however, is that you may lose some disease and patient group support group identity as part of that. And I think Kerry may comment on that, but I think ASUK felt it very important to maintain their own identity and not lose it in some bigger structure, which is where they came from in the first place in the NHS, of course.
Yeah, no, I'd agree, and I think it all depends on the types of conditions and things as well. I think because Alström, you know, can potentially affect every organ in the body. There's so many different things that needs included, and yes, there's some crossovers with other similar conditions, but there are also, you know, things that are really unique to Alström that we wouldn't want to dilute that, and we wouldn't want our patients to get lost in that service because we are such a small group, we are ultra rare. So I think that's the concern sometimes within rare, that I'm sure a lot of people living with rare conditions experience, that when you are so rare, you get lost in the bigger picture, and people don't understand. You've got that lack of expertise, that lack of knowledge, and you're left rattling around in a service and trying to get your head around it, and it's really, really tricky. But I think there's also services out there. We tried to do something similar, as Tim mentioned, for ciliopathies. There are a group of ciliopathies who don't have a service, and we were trying to look at a possible model that can support those services. And and also when you think not every service has a patient organisation, that's linked to them, and patient organisations come in all different shapes and sizes. Our model of working works for us. We've been fortunate to have paid members of staff and things. Not every patient organisation would want that, so they wouldn't want to have those kinds of contracts and things as well. So I think it's just, I keep saying it, but there is no one size fits all.
Yeah. I was going to say, we can see lots of questions in the chat. We will try to get through as many as we can. So bear with us. So next question. There's growing interest from industry to support rare disease services, but scaling highly specialised models is complex and often inefficient. What would need to change at a system level to make successful models more transferable without losing their specialist integrity?
I guess I start off with that. I guess we need to rethink the funding model in the NHS as the NHS England transitions into Department of Health, etc. as well. At the moment, you've got highly specialised services where money is top sliced across the NHS, and then you've got specialised services run by integrated care boards, and then you've got other services below that too. We need some more joined up model, taking the best bits of the existing model and then making it more enabling to actually support the development of more rare disease services that affect more than 500 people in the country. You can see economies of ways of doing that, particularly in big providers that provide multiple specialty services that would be obvious homes or bases for these to work together more collaboratively. The other thing that would really help to change is I think that the NHS trust system, whereby each NHS trust is its own legal entity, and so there's sometimes contract issues or confidentiality issues across trusts, and to try and break down some of those barriers so that trusts were encouraged to collaborate, particularly in the provision of rare disease services. In other ways, that would also help as well, I think. So there are some structural things I think that could change to enable rare disease services to be delivered more effectively.
Yeah, I think there's some examples in that hub and spoke model where on kind of certain centres developing expertise in rare conditions or similar conditions, but I think what my suggestion would be not to lose, there is still that need for that patient support and understanding that, whether that can be delivered in, from an organisation for more conditions rather than being a condition specific. But I think not losing sight of the need for that, to really listen to what people's individual needs are.
And there might be some opportunities. Yeah, there might be some opportunities to formalise partnerships between the NHS and industry sometimes in the rare diseases. That's an unexplored space really, where I think there's potential for further development really, working in partnership to deliver, particularly when new treatments come along. Yeah.
Brilliant. You mentioned the success grounded in a good patient registry at the outset. What was the legal, ethical and governance around your registry? Was it patient organisation of healthcare or university-led, or was it hosted by a third party?
So the database that I've referred to today, it's not a registry as such. It's a database. So it's a very comprehensive database, but it's a UK only database. The database that we use for our clinics. So in there it contains lots of information in terms of people's demographics. There we collect information about people when people have identified their symptoms. So there's and then we can share that information with our clinical teams as well, obviously with permission. And that's been really helpful. we have found it really tricky to develop more of a patient registry. So I know Tim's got example of the EuroWAB registry, which is Wolfram Alstrom and Bardet Biedl, which is European. We've also tried to develop a global registry as well, but getting people to complete that and keep it updated has been really tricky. So I know there's much better examples out there than the Alstrom service who've got, of other services that've got a real, comprehensive patient registry. But ours, we're very reliant just on our database.
I think in terms of identifying patients with the condition, the patient support group owning that database is probably the most effective model, I think, because they've got the network into the patient community themselves to have that. In terms of a registry where might want to keep prospective follow-up data and use that for research and identifying natural history biomarkers and potential responses to treatments, that needs probably to be behind the NHS firewall, either through the university or through an NHS trusted research environment. And there are models being developed through that. Rare Disease Research UK have had a whole workshop, I think, on registries and rare diseases. And the LifeArc project I referred to, Accelerating Rare Disease Trials, has got a whole patient recruitment portal aiming to collect that information behind the NHS firewall that'll be useful for identifying new treatments and natural history in the future.
Okay, thank you. I've got one final question for you both. Looking back now and all that you've achieved, what one piece of advice would you give yourself if you could? Who wants to go first?
Yeah. Okay. So can I have two? So my first one come up in the chat. So my first one would be to really build in the need for a care coordinator right from the very beginning. So I think within our service, we have clinic coordinators and we've had family support workers. Our team have really had to develop into that care coordinator role. And I think it's something that's really important because it's not just about navigating the specialised service, it's about navigating everything else around that family as well. And and if you're really going to have a holistic approach to supporting somebody with a rare condition, you've got to have somebody there that can help navigate the real complex systems that we have to deal with day to day. And then the other one would be building in succession planning. I saw that just pop into the chat. I think that's really important. And I think Tarek Highwatt, who's our adult lead, I think he gets really offended when I keep asking him about succession planning because he keeps telling me he's not ready to retire yet. But it's something that, is really important because we need to make sure that not just about keeping the service going, but it's that expertise, building on the research and really, making sure that that we keep those students and everybody interested in rare conditions and, making it a place where people want to work and share their expertise.
Well, if Kerry can have 2 points, I'd like 2 points as well in that case then. My first one is don't overpromise. Don't promise to deliver more than you're going to be able to deliver. It's very easy to say to patient support groups and promise them the world that you can solve all the problems and stuff, but we can't. And so it's better to underpromise and overdeliver than the other way around, I think. And the second one that I feel I've learned is I should have planned better for service expansion over time. And I think for all the different services I've mentioned, as we've set the service up, it attracts more clients and the services have expanded. Patient numbers have expanded beyond the capacity of the services to provide care for them. And I think I probably would have liked to put in a better plan at the start about how we would expand those services to meet increasing need as time goes on. I have to say our NHS commissioners have been very sympathetic to that and really, really helpful to try and address that. But that's a problem, I suspect, for all services when they start off.
Brilliant. Okay, thank you both so much. That was so interesting and so informative.